Hello, everyone. This is RealTime from Farley. I'm your host for this session. Welcome to Advancing and Implementing Consumer-Directed Health Information Exchange with the CARIN Alliance. Your presenter is Ryan Howells. He's a principal at Levitt Partners, and he's also the program manager at the CARIN Alliance. Ryan has indicated that he wants your questions at any time, so please put them in the Q&A and I will interrupt him whenever we think it's relevant. And he also brought two team members who he will introduce shortly. Ryan, let me give it over to you.
Thank you, Ward. Appreciate the opportunity to chat with you today. And I will share my screen. And looking forward to engaging with the community today. We always love Dev Days, and we hope that there will be a time soon when we can meet again in person. So thanks for joining, everybody. I'm going to go through some content today. With me, as Ward mentioned, is Amol Vaez. He's the Chief Architect at Cambia Health Solutions, excuse me, and has been instrumental in helping us to develop the CARIN IG for Blue Button, which we'll talk about here in a moment, in helping to co-author that implementation guide. We have also got Mark Roberts on the Levitt Partners team. Levitt Partners runs and manages the CARIN Alliance, and Mark has also been instrumental in working with HL7 and the broader technical community in these standards making processes. So I think folks have a pretty good understanding of where we fit, but just in case you're here for the first time, you know, one of the things that we do today is exchange data in HIPAA via providers and payers and data use agreements and business associate agreements and other things. Very well-established regulatory infrastructure that we have today, which is, you know, the primary way that we send information back and forth. Where the CARIN Alliance fits is it fits exclusively in moving data between two regulated environments. So moving it between HIPAA in the US and the Federal Trade Commission. It moves between two different regulated environments because a consumer is making the request through an app of their choice via an auth request and a specific Firebase API that would come to them in an app. And so, as you can imagine, there are obviously APIs that are needed for and technical components that are needed for that exchange to work at scale. But there are also a lot of policy components and best practices and codes of conduct and other things that need to be in place as well to ensure the data is secure and private and available and accommodates for all the best practices out there in terms of how that data should move between regulated environments. And that's, while I think there's other fire accelerators out there, which we are one of, that working exclusively on just the HL7 implementation guides, we do some of that work, but we also do a lot of policy work. So we're going to provide you an update on both sets of activity and work that we are doing to see if it would be valuable for the overall community. So as I mentioned, been around for a while. For those who don't know, we've got about 70 organizations roughly that are participating in there, including a lot of the big tech companies. Amazon is one of our newest members and has joined CARIN, as well as Google, Apple, Microsoft, and others. All the major, really payers that are out there, Humana and United, CVS, Cigna, Evernorth, others that are there. A lot of EHR vendors and some of the provider community also, and a number of the apps too. So we'll talk about that in a little bit more detail. I do want to mention as an aside, if you're interested in, and I'm not going to talk about this today, but I know it's been getting some press recently, CARIN is also participating in what's called VCI, the Vaccination Credentialing Initiative, vci.org. I'm not sure, there may be a Dev Days presentation. I haven't actually looked on the most recent agenda, but if folks are interested in talking about that in a little bit more detail, we're happy to talk about what we know. We're on the steering committee for that group that's implementing smart health cards, and happy to talk about that during the course of the presentation or at the end. So how do we kind of view this ecosystem? Well, we kind of view it in four real buckets. One is identity and access management. That includes is the person who they say they are, and also is the organization who they say they are. And we view that as being absolutely critically important to making sure the right data gets to the right person and the right organization or entity, in this case, for example, an app, every time. And so we've spent a lot of work, a number of years actually, working on this problem of digital identity. And we'll talk a little bit about our thoughts on that. Number two is API Gateway, which you all know about. Payers and providers are now implementing it as of July 1st. Really every major payer or provider in the country, especially CMS one, should have a FHIR API Gateway in place, which is really proliferating the adoption of FHIR, which we're extremely excited about. Three is this application registration process. You may have heard about UDAP and some of the work that's been going on there within the ONC FAST community. We think that to make this work at scale for consumers to use any app with any FHIR endpoint, payer or provider in the country, 900 plus CMS payers, there's obviously thousands of providers as well. We're going to need a streamlined way to do app registration. So we're going to talk about things and work that we are working on within the CARIN Alliance to be able to help the industry start to streamline that process and also to establish trust in the overall ecosystem for how that process should operate. And we're very open to hearing the group's thoughts on that. And then finally, a consent-based data sharing framework. We think that individuals are going to need to consent into how they want their data to be shared, both outside and inside HIPAA. Ways, and I know that inside HIPAA right now, it's a HIPAA authorization, but we think that it could be a competitive advantage for a lot of business associates or covered entities to allow the patient, once they gain access to the data through an app of their choice, to then consent into how they want that data to be shared, used, accessed, managed by the app, but also potentially by others in the HIPAA ecosystem. We'll have to see how that unfolds, but we certainly think that patient choice is going to be critical, and member choice is going to be critical in terms of how the data is going to be shared in the future. So kind of where we sit in kind of this overall ecosystem, and this is really primarily the CMS final rule that came out 9115, is we sit really kind of right here. DaVinci has a number of different implementation guides that were referenced as part of some CMS supplementary guidance around DaVinci Formulary and Payer Data Exchange and PlanNet and others. The CARIN IG for Blue Button was also mentioned in that information that was published by CMS. And so we're going to talk about that a little bit more for July 1st, but we know that a lot of payers are implementing that for the July 1st deadline. There's also real-time pharmacy benefit check, which is a little unique in the sense that it's not required by the CMS final rule. Really, none of the implementation guides are required, but they are referenced and highly encouraged. But real-time pharmacy benefit check, DaVinci Formulary, what that does is says, hey, if you're on a certain set of drugs, which plan would be best for you? So it's really helpful in plan selection and open enrollment. What it lacks is the ability of, after you've selected a plan, how do the specific drugs that have been prescribed to you, how do they affect your out-of-pocket costs? And that's where real-time pharmacy benefit check comes in and see what CMS calls the real-time benefit tool. So we're going to talk about both of those two today. So update on our implementation guide. So we are working on three. One is one that I think most folks know is the CARIN IG for Blue Button, which builds off the common payer consumer data set as a data model for us to be able to leverage. We published the STU one back in November. We've made some minor technical corrections and stability fixes to that in May, and we anticipate, once it gets through TSC, to publish those in the June timeframe that you'll see as an STU 1.1 version. And so you'll see that forthcoming. And again, all that information is in Jira and Confluence and other tools within the HL7 community. We also have this draft mapping of oral and vision for STU2, but we're really still waiting for the payers to move to STU2. And we'll talk about that in a second, but we've got some links there. The second implementation guide that we are focused on is this consumer-facing real-time benefit check. We published that actually last year in August 2020 as a STU1 version. And we've been in conversations with the major PBMs that we anticipate after July 1st, we'll be able to start to really engage them in terms of testing. They have expressed interest in testing this with us. As many of you know, many of the PBMs are owned by the health plans. And so it's basically don't talk to us in July 1st, which makes total sense. And so we're waiting for that to happen. And then they're building out that fire support so we can work with them going forward. And then the new implementation guide this year is what we're calling the CARIN IG for digital insurance card. And what that does is it's mapping those artifacts to really allow an individual to retrieve proof of insurance coverage via fire, so that essentially the patient can have on an app of their choice a digital representation of the paper insurance card or the plastic insurance card that's in their wallet. This does not perform an eligibility check. It doesn't have anything to do with that other than the fact that it's just providing a digital representation of the insurance card so that potentially that information could get passed to a payer who could perform that eligibility check on the consumer's behalf. But what the insurance card is simply that. It's simply just that digital representation of the card itself. We've recorded our kickoff meeting. It's there in the link. It was held on May 20th. The broader HL7 meetings after the holidays and things are actually starting this week on Thursday at 1 o'clock. We've got information on that on the Confluence page. And if you subscribe to the HL7 listserv, the CARIN listserv, you'll get information on all that information, so that we think that there's going to be a lot of parties, I think, interested in this simply because there's an opportunity for this to be used in probably multiple different use cases.
Ryan?
Yes, go ahead.
There's a question that came in on the second point.
Sure.
How does the real-time pharmacy benefit checks differ from the regular benefit checks? Why does it need a separate IG only for pharmacy? Okay.
Yeah, so there's two types of real-time benefit checks. So there's business-to-business real-time benefit check between the PBMs and the providers, and there's a business-to-consumer real-time pharmacy benefit check. So the payer-to-payer, the B2B real-time benefit check is largely leveraging the implementation guide that was published by the Pharmaceutical Standards Organization and CPDP. And so they have published an EDI-based implementation guide for making that work at scale. This one that we have for consumers is a FHIR-based API implementation guide. And so the hope is we've kind of co-published really this one with both NCPDP as well as HL7, and that there's some work that's going on in both groups to be able to reconcile those two things and find ways where we can do it. But this is the only one that actually is FHIR-based at this point. But we hope that we're very much in close contact with the folks on the NCPDP side to make sure that we reduce the amount of overhead associated with making those connections.
Nice. And then on the third point, there's a question from Santosh. Does it also deal with the OCR image reading of the physical card?
No, it's not going to include that. It's just going to include the data elements associated with, what potentially could be on a card. So we don't really have any OCR characteristics that we'll build into the IG. The hope is that it'll cross all lines of business, though, Medicare, Medicaid, and commercial, and that any of those data elements that potentially could be on one of those lines of businesses for that card for the individual, it could actually include as part of the data model.
Great, thanks.
Good questions. All right. Again, interested in any of these, sign up for the CARIN listserv, and you'll get all the fun information related to it. More links for you, but that'll be delivered after. We talked about CARIN IG, the blue button for STU2. This is a tentative timeline. Kind of as I mentioned earlier, what's the big caveat here is that we still don't have really any payers or dental claims providers that are really ready to test any of this. And we've got a draft kind of outline, a mapping that's on our website. It's on the previous link, by the way, on the Confluent site, where you can see dental and vision right now, but we're really kind of waiting until that fire infrastructure has been built up by the dental providers so that we can start to test this. And the hope is it'll be later this year. We'll see if we can hit the August date, if the payers are ready to do that. If not, that January date actually may get pushed because of we may not make the HL7 timeline there. So more to come on that going forward. We do have a reference implementation out there. We didn't as of a few months ago, but we do now. So folks need that information, let us know. The test scripts are also out there too for folks to be able to leverage. There's some preliminary synthetic data out there. We're hopefully working on getting some more. That's, I know, a problem across the board. I know DaVinci's having that issue and others. We're hopeful that we can be able to work with our partners to be able to provide more synthetic data for more testing to occur, as we recognize that once we get to production, it's not a good place to test anything. So the hope is we can get some more synthetic data that looks similar to what we'll see in production, but that's still to be determined. But if you've got some ideas on that, we're very, very open to hearing about thoughts you have on getting some de-identified information to be able to test with. Let me move on to beneficiary real-time benefit check. Some folks may have missed this, but from a policy perspective, CMS was kind of going back and forth last year about this topic. They call it a beneficiary real-time benefit tool. And they first said it's in the proposed rule, they said it's going to be required. In the final rule, they said, nope, we'll get to it later. And then they did what's called a double final rule. And so in January of this year, they did this double final rule on the CMS payment rule. And they said, nope, it actually is going to be required now as a beneficiary real-time benefit tool, that by January 1st, 2023, that Part D sponsors must make this information available, which is information that's in that real-time pharmacy benefit check FHIR API that I had mentioned earlier. There's also an interesting clause in here that there's an ability to Part D payers can actually provide rewards and incentives that actually meet the following obligations for individuals to be able to use the beneficiary real-time benefit tool functionality. Want to be clear that they have been clear in CMS that this doesn't have to be an API. It could be, but the language allows for it to be a website or portal or other things. But hopefully, because you're here, you recognize the value of an API, and that's hopefully where we kind of move forward. So, but there's a link here at the bottom if you want to run that past your government affairs folks and policy folks. But we're excited about this because, we anticipate, like I said, this being made available across the board for members that will provide them a lot of good information they don't currently have. This is more information on real-time benefit check and specifically the real-time benefit tool. There's a link here at the bottom about where you can get that information and see the StuI version for more information there. And again, very open to your thoughts on feedback around that and JIRA tickets. Let me move on now to, well, let me pause there. I didn't get a chance actually to ping my team, but let me go back on the CARIN IG side. Amal, I want to turn to you first. I know you had some comments you wanted to make about STU 1.1. Let me turn it to you just so you can make those things, and then we'll move on to the rest of the deck.
Thanks, Ryan, and hi, everyone. Just wanted to kind of quickly characterize the STU1 update, also known as STU 1.1.0. We've been getting several questions from folks around, hey, should I move to the update or wait for STU2? And so towards that, wanted to kind of, give a generic characterization of that update. The changes in that update are basically clarifications and fixes to certain broken and incomplete things within the STU1. And they're all based on some excellent industry feedback after STU1 was published. And so the scope of these changes is narrow, and basically these changes remove hurdles and issues that implementers may encounter with STU1. The other thing that I want to kind of highlight is the upcoming STU2, to Ryan's point, that will likely be published in Q1 of next year, around Q1 of next year, will leverage the STU 1.1. And so for payers wanting to move to STU2, it would be great if they can get started or prepped up for that by adopting the STU1 update in advance. And that's pretty much it as far as characterizing the update. Mark, did you have anything else to add to that?
Mark, go ahead, Mark.
Yeah. Nothing here.
Okay, perfect. Thank you, Amal. Thanks, Mark. Appreciate it. Let me jump into some of the, the other work that we're doing here, if it could be of benefit to the overall group. So I mentioned we're doing some work on app registration. So one of the things, as we mentioned, that we think to scale interoperability is the ability for apps to be able to easily, securely, and really transparently be able to register with endpoints. This has been done already for a number of years now, and we think we've learned a lot as an industry about what has worked well, what hasn't worked well, and ways to improve. And so we have developed with our app partners really a best practices guide on app registration and what that actually looks like, that we'll be publishing for everyone to take a look at, likely later this summer. And to get a better understanding of how they, as potentially a data holder, could be able to make this information and to be able to implement a lot of these best practices around app registration. We're excited to present that. We're excited as well to get the input of the broader industry on ways that we can continue to improve this. I know the payers have learned a lot from the EHR vendors, for example, on what has really went well and what maybe hasn't gone well. We're grateful for the EHR vendors and really, carving a path through the wilderness, so to speak, on this topic. And we know we're all learning together. But this is, and I think we're improving as we go along. It's just a matter of how do we start to take those best practices and find ways where we can streamline them in such a way that we still do all of the things we need to ensure that we validated and tested and they're conforming to the standards themselves, that they've got robust developer portal and information and content for the developers, that they've got an open sandbox, for example, for folks to be able to test in with synthetic data. So all of that can be done even before the individual app actually connects or calls or reaches out to the payer or the provider. All of those things we want to try to capture in this registration guide. So you'll see that come out a little bit later this year. You'll see that posted on our website. And again, super open to hearing feedback from the broader community. Folks should be aware of the code of conduct that we've put together that's on our website that really develops informed choice and app attestation and purpose specification around how this data should be used, managed, and accessed. We've been really, really pleased to see a number of things happen as a result of that code. It's been adopted by a number of the major payers and many that aren't listed here in the industry, which has been fabulous. It's also been referenced in the CMS final rule as a best practice. CMS has actually taken some of this language and put that in CMS Blue Button 2.0. The VHA has supported it, others too. We're really grateful to see the adoption of the code. We recognize this as a first step, but the good news is that now we have an ability to at least provide some baseline approach or framework for how individual apps should be able to handle, use, manage, access this information in a consent-based data sharing model. For those who don't know, we've listed the apps that have self-attested to the CARIN Code of Conduct on myhealthapplication.com. You also can get easy links to the privacy policy and terms of service. Many of the payers that we are working with are asking for where those apps are that have attested to the code. And so we've directed them here. signed by their C-level executive within their organization. We've also worked really closely with ENAC on their certification program that they have developed, so that these apps can be independently certified, and ultimately that information will be posted on the website as well. And so, despite the fact that really the CMS rule talks about this idea that any app can connect as long as they follow the open standards, we're really looking for ways that we can build this trusted ecosystem of apps. So it really can be extension and an improvement on how data is protected, shared, managed, accessed today. That's really the goal. And the goal is to really improve and to be transparent about how this is occurring. And so we're excited to partner with the community on how that works. We're also working a lot. Yeah, go ahead. Let me pause there. Any questions that are coming in?
Thanks, Ryan. There's a question on your registration guide, whether you're also outlining patient matching requirements for third-party apps in there.
So the patient matching work that's going on right now that we're supportive of is mainly going on within FAST and HL7. So there is a project in the digital identity FAST Tiger team at ONC where they are working with HL7 to develop an implementation guide on patient matching attributes, characteristics of an approach for how to do that. So more is on, I know, the FAST website if folks are interested in that. I think from our perspective, we likely will reference that in the work that we're doing in the app registration guide. So we don't want to duplicate any additional work that's already being done, but just for folks' knowledge, that's really where the work is happening, to our knowledge, at least. There may be, obviously, there's sure other places where that's occurring.
Okay, thanks, Brian.
Sure. We are also doing some work on digital identity, which you may know about. And so we wanted to talk about what we're doing there from a policy perspective on identity. So folks are aware that right now the Trusted Exchange Framework and Common Agreement that came out from the ONC requires a NIST 863 IL2 digital credential to be established for individuals that are participating via an app of their choice within the TEFCA. And so we are looking for ways where we could say, well, what would this actually look like if, in fact, we envisioned a world where an individual could go into an app, get identity proofed one time at an IL level 2 or higher, and have that digital credential that includes all of these trusted identifiers associated with that. Could they avoid doing another OAuth process with providers and payers? Could we set up a trusted ecosystem where, because the identity event actually occurred in the app and because it's been certified by a third party, could there be an ability for that identity proofed event to be trusted by other relying parties in the ecosystem? That's kind of the question we're trying to answer. And we're trying to build a policy framework that would help support that. So we've got a Federation white paper that's actually on our website here that you can read more about how we're thinking about this. But in a nutshell, that's really what it is. There would be multiple identity providers out there issuing these IL2 credentials. There'll be certifying organizations that would certify them against the NIST guidelines and make sure the conformance testing, et cetera. And then there would be contractual language in this, what's called Digital Federated Trust Agreement, that would actually think of it as a certificate policy, a consensus certificate policy across PKI and API-like activities that would actually link these trust framework organizations together. So we spent a lot of time with these trust framework organizations over the last year in developing that, and the hope is that we will publish that this year is the plan. And that we'll work on, we've already had folks that have been really interested, both identity providers and relying parties, to actually test this out. Does it work? Could we establish the digital identity once? And could we then be able to leverage it or utilize it on an app, on a payer, on a provider, and others? So we're excited to report a little bit more about that later this year when we run some pilots on that. And if you're interested in doing that, let us know. these are some ways that we are thinking about how these digital identity components could be pulled together. Obviously, for July 1st, everyone, it's already here basically. So, there are two ways that we're hearing identity is being used for July 1st. One is portal-based via Smart, which makes total sense, and we're 100% supportive of that. The other one is more of an IDP, an identity provider-based approach for doing this. For those, we know that there are many payers out there, especially state Medicaid agencies, who don't currently offer a portal to their beneficiaries. And so as a result of that, we're really encouraging them to go out and get in one of these identity providers to provision the user so that that identity event could start in the identity provider system. And they could use Smart to actually then say, hey, how do we get certified by the third party? And then how do we figure out a way to authenticate in? And this is helpful because it's the start of this portability of the identity itself across multiple systems. On payer-to-payer APIs for January 1st, again, very similar approaches as was mentioned up here for patient access, but we also get into this kind of concept about organizational identity. We not only need to know that it's Ryan who is making the request and that I am who I say I am, but we also need to know that it's a third party application that is making the request, or we need to know that it's Humana that's making the request, and we need to know that for certain. There's something called GLIFE, the Global Legal Entity Identifier Foundation, that we like a lot in terms of how they establish organizational identity, where we could really move into a world where, and it's digitally signed certificates that they operate off of, but we could move into a world where we would know for certain that both the organization and the individual is who they say they are. And so we're doing some work there in terms of the federation agreement, as well as the individual and the organizational identity. So just some initial preliminary thoughts of how we're thinking about this and how these pieces could come together. All right, I think, Ward, I am done. I think we've got about 13 minutes left. There's the information if you want to reach out to us. Always interested in hearing from this community and happy to take some questions.
That's great, Ryan. Thank you. Let's see, there are some questions. And I think I'm going to ask someone to unmute themselves if they don't mind. Let me try to find her. Let's see.
Hello.
Janice.
Yes,
Hi.
this is Janice CARIN from the Massachusetts Health Data Consortium. Which of my questions would you like me to?
The one you want most. There's room for both, I think. Go ahead.
Okay, actually, so just a comment. This was actually what I was asking about, the patient matching, what you were just talking about, how you identify the person in the third-party app with the person in the payer or the provider. But as far as the questions go, I'm still a little bit confused about the why you're saying that because it needs to be FHIR, the pharmacy has to be separate. Why can't we have a single FHIR-based implementation guide for consumers for any use? Why does it have to be specific to pharmacy?
When you say any use, Janice, I'm not sure I'm following what you mean.
Well, I mean, real-time benefits would be useful for almost any service.
I'm sorry. So you're expanding the definition of real-time benefits to include
right. So it just seems weird to me to go through all that work to define something that's very specific to that can only be used for pharmacies, when you could define something more general that could be used for any specific real-time benefit use case.
Understood. Gotcha. So the implementation guide itself is just focusing on pharmacy right now, but obviously the resources that are being used there, as you mentioned, could be used for other purposes. We just didn't pivot the IG to specifically focus on those other use cases related to kind of real-time benefits. There's other implications of what that would look like in production. And frankly, in the implementation guide itself, it would be a different implementation guide, but there's no reason you couldn't go down that path. I think we wanted to start with pharmacy primarily because there was a policy push for pharmacy, and there has been for a few years now, both on the Hill as well as through regulation. And so we wanted to make sure that payers had the ability to have a published IG available if in fact this became a requirement, and lo and behold, in January it did. So that was the main reason.
All right, thank you.
Sure.
Were those both of your questions, Karen? Janice?
Yeah, I don't see anything else that's marked unanswered. I thought I had something else, but I've forgotten it if I did.
Janice,
Okay.
your other question was about matching, I think, and I don't know if I did a good job answering it.
Yeah,
earlier.
well, I actually, like I was saying at the beginning of this, I actually was asking about the stuff that you covered later in the digital identity.
Oh.
Okay.
So that's what I meant by patient matching, not general patient matching, but patient matching in the context of the third-party apps connecting to the other systems. Yeah,
so I think the quick answer there is that while those conversations typically have started with patient matching and then fell into identity, we're doing the opposite. We're starting with digital identity, and then we're going to go into matching and hopefully leverage the member in terms of how they can be able to help with that process. So we're kind of starting with the person, and that the person is the source of truth for their information. And therefore the matching problem hopefully will go away over time if in fact the person actually essentially allows for their digital identity to be portable with them. So we'll see how that works. But that's the real difference in how this all works. It's a subtle difference, but it's actually huge. We think it is huge. Others may not, but so we're just taking a different approach to a common problem. Good questions. Any other?
Thank you.
Yeah, sure.
Great, Ryan. I think those were all of the questions that we had. If people have any other questions, feel free to put them in the Q&A. There's one question I think that's specifically for you on synthetic Medicare data, if you want to reach out to someone. But I'm going to leave that one to you. So put your questions in the chat, and then Ryan can come back to them later. Ryan, thank you very much for your time.
Thank you. Thanks, everybody. Appreciate it.